This is the MyHeart.net podcast. This show is produced by Dr. Philip Johnson in conjunction with VitalEngine.com. Please welcome your host, Dr. Alain Bouchard of Cardiology Specialists of Birmingham, Alabama, at St. Vincent's Medical Center, part of Ascension.
So welcome to our podcast in MyHeart.net. And today we'll be discussing, can a heart attack affect your cancer? This is our series on Cardio-Oncology, and today we have our special guest, Dr. Liu, who's Director of Cardio-Oncology at Ascension Seton in Texas. So Jan, thank you very much for taking the time, and welcome to MyHeart.net.
Thank you, Alain. It's great to be back here again to have more fun to talk about this very important topic for this very special patient population.
So today we'll discuss some of the interaction between cancer and heart disease with Dr. Liu, who's obviously an expert in the field. He's done some of the seminal work and the research in that field. We'll discuss how cancer treatment can affect your blood vessel, and in particular, we'll discuss how new targeted cancer therapy can affect the blood vessels. Finally, we'll discuss some of the challenges in treating cancer patients presenting with a heart attack. So, Jan, most of us are new to this world of cardio-oncology, but obviously you've been there since the very inception of the field. And in particularly, I can recall one of the articles you wrote in 2009, you published on the shared pathway of cancer and coronary artery disease. Can you tell us a little bit more about this?
Yes, absolutely. So it's actually interesting how I got initially involved in this part of very important research. That is a shared pathway between cancer and heart disease, and more specifically, coronary artery disease. A little story is that that's the time actually I was actually doing my postdoctoral research training with a very, to me, one of the most prestigious oncologists in the world is Dr. Norman Sharpless. Now, we had a very common interest. That is a molecule called P16. Now, Dr. Sharpless, he's the one who really, done a fundamental breakthrough work on P16, nationally and internationally. But at that time, I was really interested to look at some of the molecular pathways for heart disease, because, as a cardiologist, I'm going to look at, something that's relevant to the disease I'm directly treating. Then in 2007, there's actually a milestone of genomic-wide association study, or what we call GWAS study. That, basically that's the year that total, I think, 7 studies came out, all of them which are large-scale. They're all of them published very important journals to establish the highest risk genetically, for example, SNP or polymorphisms, in our DNA that is associated with coronary disease. And that's the time that biggest signal, or the one that has highest risk genetically, is right next to the molecule P16. Now, P16, as some of you may or may not know in terms of audience, it is a very important tumor suppressor gene. So it is actually the absence of P16 could lead to many types of cancer, such as melanoma, lung cancer, all of which. So it is it's very interesting to me at that time to see that, the genetics risk is actually right next to this tumor suppressor gene when we actually are talking about coronary artery disease. And then at that time, we really put together some, research, both actually in a molecular level, in mouse model, and in human patient level, have shown that P16 is actually directly involved in the development of coronary disease. And fundamentally, what we find is that, P16 essentially is a molecule that controls cell cycling or cell proliferation. And because absent of P16, you have uncontrolled self-proliferation that may lead to cancer. But the same process, if it happened in the heart artery, we talk about a plaque formed in the artery, and then some of the immune cells start to proliferating uncontrollably, and that will lead to atherosclerosis or coronary disease, and that's essentially the same disease process. It's basically uncontrolled proliferation. Of course, we showed, by knockout mice, basically we created mouse that's deficient in P16, especially in their monocyte. And what we find is that, yes, those animals could have higher risk of coronary disease or, in general, atherosclerosis. We also looked at some of patients where we find that, if they have a low expression of P16, they could be a much higher risk, genetic risk for coronary disease. And that mediator is RNA that is bridging the P16 and the genetic polymorphism that's found by those GWAS studies. So at DNA level and also a mouse model and a patient level, we have luckily shown that no, there is a connection, and this connection really showed there is a shared pathway between cancer and cardiovascular disease, specifically in this situation, coronary disease, but also other studies later on. For example, the study in 2018 showed in heart failure patients, actually there's connection between heart failure and cancer development. And then in 2020, 1 year after the last study, there's actually studies shown that in breast cancer patients, the heart attack could increase the risk of breast cancer progression. So the heart attack could be directly linked to the breast cancer, disease process. So it is really, obviously shocking, but, at the end of the day, when we find that back in 2009 and gradually become one of the most important foundation for cardio-oncology, because now we're talking about cardio-oncology is not only, just the overlapping of heart disease and cancer, not only is just cardiotoxicity from chemotherapy, but we're also talking about genuinely the shared fundamental molecular pathway between those two disease processes. And that's, to me, it's very encouraging as a cardio-oncologist, and very important when we utilize the treatment for this, specific patient population.
Well, this is very important, this interaction, and particularly relevant to the 16 million survivors of cancer. There's also a lot of shared risk factors among cancer and cardiac patients, aren't they?
Absolutely. So, as you said, 16 million, and then by 2040, it's going to be 26 million, and by projection. And so, a lot of cancer survivors, and they all, have very similar risk factors, and those risk factors not only could have contributed to the cancer development, but also could be very important risk factor for cardiovascular disease. They're definitely a unique patient population, and not only for us to monitor their heart disease, but also it's very unique population in terms of how we treat their cardiovascular disease, because their response may be different when you have a cancer and when you're on chemotherapy.
So this is particularly important for our patients with cancer. How frequently do we see acute coronary syndrome or heart attack in those patients?
So surprisingly, to me, surprisingly frequent, than we initially thought. Obviously, it's still a relatively smaller risk for chemotherapy compared to other common risks such as, fatigue, low energy, all that. But we've actually seen significant occurrence of coronary artery disease, vasospasm, or myocardial infarction in the setting of different cancer therapeutics. And I'll give you several examples, right? One of the most common one is probably 5-FU-based therapy. And it is very traditional therapy. It's been around for a long period of time. But it's been known to be causing vasospasm. Basically, you may not have, coronary artery disease, but your heart artery may get nervous and start constricting. And that lead to this vasospasm phenomenon that could cause chest pain. And at times, if it's severe and long-lasting, it could lead to myocardial infarction. And I personally, and also my colleague in our program, in our Cardio-Oncology clinic, have treated numerous patients with this type of situation. Sometimes the treatment will be outpatient, meaning we may actually prescribe some of the what we call endothelial stabilizing agents, such as atorvastatin. We may give them nitroglycerin to relax artery, sometimes isosorbide, a long-term nitro, to counteract that vasospasm effect of 5-FU. But we also have patients that we have to hospitalize in order for them to get 5-FU infusion because the vasospasm is so severe. And we actually have cases we have to do intervention in the setting of 5-FU induced coronary spasm. So it is a big category, and obviously, when we see so many patients who's being treated for 5-FU, we see more of those, even though overall, obviously, the risk of heart attack from 5-FU still fairly small. But it's obviously severe potential risk and really needs a cardio-oncology evaluation and close monitor by cardio-oncology specialist. Another example is that we actually had a patient, a lung cancer patient who's undergoing cisplatin treatment, so plant-based chemotherapy. And then 6 hours later, we're having cardiac arrest and ended up having a coronary arterial thrombosis without any history of coronary artery disease that needed intervention, two-vessel intervention. So it's multiple thrombosis in multiple coronary arteries at the same time, shortly after some of the chemo agents such as cisplatin. And those, fundamentally, those agents could cause endothelial dysfunction and could lead to not only the risk of thrombosis, like we have talked about last session, increased risk of venous thrombosis, but also increased risk of arterial thrombosis. At the same time, lead to this arterial dysfunction, and combining those two really led to the multiple occurrence of clot or thrombosis in multiple coronary arteries. The newer agents, we know some of the small molecule tyrosine kinase inhibitors, they all could be also an add-on risk factor for arterial thrombosis. But radiation therapy, as you know, even though short-term wise, radiation therapy may not cause a significant amount of complication from arterial standpoint. But radiation therapy, almost all of them, if it's high dose, could lead to early onset or premature atherosclerosis as a long-term complication. And those patients will need to be monitored or surveilled for carotid disease or coronary disease, depends on where the radiation field was when they received radiation therapy. So, but combination of acute radiation therapy and other factors, you could also see an acute event of arterial thrombosis because radiation obviously could cause damage short term of the endothelium of the arterial coronary artery or carotid artery or other arteries. But at the same time, if the patient has other risk factors such as 5-FU treatment, and those patients are at higher risk of arterial thrombosis compared to the patient who's receiving either one alone or not receiving either one of those therapies.
This is important, and particularly in the field of chemotherapy, the oncologists are really at the forefront of personalized medicine, and they are giving some chemotherapy agents that are, have a very specific mode of action. For example, in the VEGF, where we intervene and attack the blood vessel feeding the tumor, how does it affect actually the arteries elsewhere in the body?
Yeah, and as you said, this VEGF. Most of those VEGF inhibitors, they're small molecules, and most of those actually tyrosine kinase inhibitors. So they're great treatment, add-on treatment, and also just as a first-line treatment for a lot of different type of cancers. However, as a relatively new therapy compared to therapies such as anthracycline-based, they also have several other risk for patients who have cardiovascular risk or cardiovascular disease. First of all, they could actually cause cardiomyopathy directly. They could be leading to heart failure. But second of all, they could definitely cause potential arterial complications, because the way it works, as you mentioned, is to interfere the vascular function. So very often we're seeing uncontrolled hypertension or suddenly increased hypertension in those patient population. And many times, those type of hypertension are very hard to tackle and very hard to treat. And usually requires a very strong calcium channel inhibitor to be at the first line, and an add-on such as beta blockers or ARB inhibitor to control the blood pressure. But hypertension, if it's uncontrolled, of course, it's going to be one of the important risk factor for the arterial thrombosis. But as a mechanism, VEGF inhibitor, by interfering the arterial function, will actually have high risks leading to the potential arterial thrombosis too at the same time. So this is also a new patient population we really actually pay a lot of attention to. We're cautious because they could develop cardiomyopathy, so we wanted to make sure their heart function, their global longitudinal strain, which is more sensitive marker of heart function, those are normal before during the treatment, but at the same time we really do want to pay attention to how their symptom is, whether there's any indication they could have coronary ischemia or other arterial complications, or a peripheral ischemic arterial disease such as ischemic legs or ischemic tones.
So we talked about how the cancer treatment can affect the blood vessel in the patient, and we have now the situation and the challenge where we have to treat sometimes patients that present with a heart attack. It happens quite commonly. It's about maybe 5 to 10% of all the patients coming with acute coronary syndrome. There are also cancer patients being treated with those chemotherapy. There are some challenges in these patients. They have a tendency to bleed. They have low platelets. How do we treat patients with a heart attack and a cancer?
No, very important, but absolutely challenging area of practice, as you mentioned, very precisely. Those cancer patients, obviously, they're already having a lot of comorbidities, and they probably been receiving some chemotherapies, other therapies. So they're usually actually fairly sick from clinically. And then obviously, if they're complicated with arterial thrombosis event or heart attack, for example, and not only the treatment itself could cause potential more complications, but also patients themselves they're not intended to tolerate procedure or treatment as well compared to someone that's completely healthy. So those are the important factors to consider. But the other factors to consider directly is how we treat heart attacks. As you mentioned, we treat heart attacks with, again, blood thinners, antiplatelets, and stenting. The procedure or surgery is aimed to open up the artery, or what we call revascularization. That can be done by the stent put into that blood vessel, and then followed by, most of the time, 2 antiplatelets, or what we call surgical revascularization. It's what we call bypass surgery. And it is such an important area of practice, and I think to me, also it's one of the most challenging area of practice for our interventional cardiologists, because basically means your risk of complication is much higher compared to a regular patient population. But here are several, I think, criteria or rules we stick to. Is first of all, we have to look at the balance of medical therapy or medical management and procedure-based revascularization. So can this patient be treated with medication only if the patient is super high risk for bleeding? For example, if their platelets is only 5 or 10, or they already have active bleeding, they have diagnosis of brain cancer. So in those patient population, we have to be able to say, hey, which type of therapy is going to provide the best, safest overall treatment so that the patient can have the best overall outcome. And then balance that with the other side is the treatment will be procedure related, either PCI or what we call stenting, or bypass. When we consider a PCI procedure, I think most basic information we want to make sure that we have is the platelet count. So we do want to make sure the patient has sufficient amount of platelet, and if we do have to transfuse platelet to reduce the risk of bleeding, we do that. But I think in general, if a patient has a platelet amount of more than 100,000, that's area that we feel much more comfortable to go ahead to potentially treat an acute heart attack with PCI or stenting. Obviously, assuming the patient does not have any other significant conditions such as brain cancer and high risk of bleeding, because any stent we put in, we have to follow with 2 antiplatelets for up to 6 months to a year. So that part has to be considered. So based on their lab data at the time of heart attack and the patient's overall status, we'll make a decision. It's going to be a hard decision either way to do either intervention or not. And if a patient really have no significant amount of other contraindications, just low platelet, and then we can transfuse the platelet above 50 at times, we can still do, obviously, PCI or stenting. And obviously, the risk is a little higher in terms of bleeding, especially when it comes to access. We do our cath, radially, and femorally, and then no-brainer radial access is probably much preferred in this situation. To me, it's a superior access, superior way to do cath anyway in overall population, but in this specific population, I think radial access is going to be even more important because the risk of bleeding is going to be much reduced in that situation. And if the patient does not have any radial access, and we have to go femorally in those situations, then I highly encourage to have our interventional colleague to put in a closure device so that the risk of bleeding from exercise is going to be much reduced in that situation. So I think, overall, it's really the balance of medical management and procedure or surgery-related treatment, and then look at the acute situation, look at the lab data and patient's overall status, especially their bleeding risk, their overall cancer prognosis, and then obviously make a decision going from there, and then maximize our effort in terms of exercise, potential need of transfusion for platelet, and potentially try to intervene the only culprit lesion, but no other, lesions at one time, so that we can reduce from our end the risk of complication, especially bleeding, when we do have to go ahead for intervention. Now, when it comes to bypass, as you mentioned, surgical revascularization is going to be tricky because it's going to involve another team, the cardiovascular surgery team. And that, cardiovascular surgery team, they're going to look at, hey, how much long-term outcome I can provide for this patient by doing a open chest, open heart surgery, and the patient will be put on external circulation. So that, I think, to me, it's going to be case by case. I think if patients do have advanced cancer and if their prognosis is poor, it's going to be tough to qualify them for bypass surgery. However, for patients who's having good response to cancer treatment, they may have really good survival rate, down the road 3 or 5 years or 10 years, then it's very reasonable to consider a bypass surgery based on a team effort, basically involving oncologist, cardiologist, and the cardiovascular surgery team together with patient and family make a decision, what we call shared decision making at that time.
So this is really emphasizing the importance of working together. Seems like the heart team keeps growing, and I think the relationship between the cardio-oncologist and the interventionalist is particularly important, isn't it?
I absolutely agree. Yeah.
Well, I think this was a very, very interesting podcast. I want to thank you, Jan. Today we discussed a lot. We discussed the interaction between cancer and heart disease. We also discussed how the cancer treatment can affect your blood vessel. And finally, we discussed some of the challenge in treating a heart attack in a patient who has cancer. This is obviously very, very important to really work together with the interventionalists as well as the cardio-oncologist The heart team is taking a new dimension in the treatment of patients with coronary artery disease. And I know next time I have a patient with cancer and a heart attack, I'm going to give you a call, Jan.
Absolutely, it's my absolute pleasure to be here today, Alain. It's really fun, and as you said, it's very important to talk about this very interesting situation, but very challenging situations. But at the end of the day, this is a very specific, very unique patient population. We love to take the best care of them. And thank you so much for having me today.
Thank you very much, Jan.
To learn more from our team of cardiologists, please visit us at MyHeart.net. You can also follow us on social media by searching MyHeart.net on Facebook and Twitter. And be sure to subscribe to this podcast so you don't miss our next episode.